Everyone, thank you very much for coming today. I just wanted to open the seminar. For those who don't know, my name's Amy. I am the co-convener of the ACT chapter of the Australasian Epidemiological Association. But before we get started, I would first like to acknowledge the traditional custodians of the land on which we meet here on the beautiful ANU campus. This is the land of the Ngunnawal and the Ngambri people. And I just wanted to take a moment to appreciate and celebrate the traditional custodians of this unceded land today. So just for those, again, who are unaware, to give you a little bit of an overview of the Australasian Epidemiological Association, we are a professional association dedicated to excellence in epi research, education, training and advocacy in the Australasian region. If this is something you're interested in, you are very welcome to become a member. Membership will allow you access to our monthly bulletin. It will give you discounted registration to our annual scientific meeting. The next one is in Hobart. And you'll also be eligible to nominate for annual awards, join our local chapters, so the ACT chapter, for example, and our special interest groups. You'll be given invitations to our various events that are not necessarily open to the public, and you'll get discounted IEA membership as well, so the International Epidemiological Association. And students also get discounted membership as well as recently graduated students. So if you're interested, feel free to scan the QR link or contact me after this. If you are already a member of AEA, then here is just a reminder of the ways you can be more involved. You can join, obviously. You can also elect to co-convene a local chapter or special interest group. You can co-host an AE event with us, present at our monthly educational webinar series, or contribute an article to our monthly member bulletin. So if you're interested in contributing, our inquiry email is there. So without further ado, I would like to introduce you to Professor Emily Banks, who will be giving our seminar today. She is a public health physician and epidemiologist, working mainly using large-scale evidence to identify actions to improve health and healthcare at an individual and population level. Her main areas of work are in chronic disease, tobacco control, Aboriginal and Torres Strait Islander health, and healthy aging. She is head of the Centre of Epidemiology for Policy and Practice at the Australian National University here. She is an NHMRC Investigator Fellow, a Fellow of the Australian Academy of Health and Medical Sciences, and she is a visiting professor at the University of Oxford and a member of the Order of Australia. So please welcome Emily for her presentation today.
Well, thanks everyone. I feel like I could be sort of sitting down with you actually, because this is a very intimate group, but also a lot of people here that I know really well. And actually it feels a bit funny to be sort of standing and holding forth when so many of you are my colleagues and friends. But anyway, I'll do it. I'll do it because I have to. No, but also I know that I also have people online. I just want to check, am I okay in the camera there, Amy? Am I bit to one side because that can be a bit funny?
You're a little off center.
All right.
Yeah, that's perfect.
Okay. So yeah, I just have to make sure, because sometimes with hybrid events you can end up with the worst of both worlds, like serving the kind of, trying to serve both things. But anyway, I will do my best. And the other thing is I'd love a bit of interaction. If you can smile and laugh at the bits where clearly you're meant to, I'll feel better. And you'll see that is a theme going through the whole thing. So I'd also like to acknowledge the traditional custodians of these beautiful lands, the Ngunnawal and Ngambri people. I'd like to pay respects to their elders past and present, to any Aboriginal Torres Strait Islander people who are listening or in the audience. And I'd like to acknowledge the disproportionate role that tobacco plays in Aboriginal and Torres Strait Islander health. And I'd also like to salute the strength and courage and resilience that communities have shown in the face of rampant colonization. So, and also express my gratitude for the privilege of working in partnership. So I'm going to talk a little bit about what epidemiology and public health are. So it's obviously a bit of a strange thing to do when there are epidemiologists and public health physicians in the audience, but I'm going to talk about it very broadly and in a way talk about the spirit of those things. Then I'm going to talk about why public health should be in the firing line. So I have spent a lot of time feeling that I've accidentally stumbled into the firing line and thought, oh, how did I do it? Why have I done it again? And I've reflected on that quite a lot. And that's the genesis of this talk has been kind of almost a personal journey through what public health is and what it means to be in the firing line. And I'm going to give some thoughts about how to deal with being in the firing line, as well as some conclusions about future challenges. So these are sort of very standard definitions. I don't necessarily need to read them out about what epidemiology is and what public health is, but essentially epidemiology is about the distribution and the determinants of health-related states. And it's also about the application of that study to the control of health problems. It is a way of thinking and acting, like epidemiologists, are. Well, I have said there's only one epidemiology joke, and it's someone says to an epidemiologist, "How are you?" And the epidemiologist says, "Compared to what?" That's hilarious. A lot of people in this room have heard that before. Public health, or also known as population health. So I think I use those terms interchangeably. Often people get confused and they think public health means the public health care system. But by public health, I mean population health, the science and art of preventing disease, prolonging life, and promoting human health through the organised efforts and informed choices of society, organisations, public and private communities, and individuals. Public health is very promiscuous, I think, or in that public health will take advances from anywhere that work and seek to apply them in an organised way. So we do draw on epidemiology, biostatistics, health services management, behavioural sciences, but we will use the law. We'll use environmental health measures. We will use pretty much anything that works with, obviously within ethical and other boundaries. It is also a way of thinking and acting. So one of the most important things, when people go, well, what does public health do? Why does it matter so much? It's very useful to think about what life was like in the absence of effective public health. And we can look to different places in the world, although, we've actually seen really important increases in global life expectancy. But I think one of the most useful things is to look at the historical counterfactual. And one of the things that humans are very good at is normalizing things, sort of accepting things as normal. So we accept generally not dying in childbirth, we accept generally not getting diphtheria, all those sorts of things. It's very important to reflect on the historical counterfactual, which gives us the examples of what happened before we had effective public health, and in fact, before we had effective medicines. So often people, if they do know that we're doing very well globally and particularly in wealthier countries and among wealthier people within countries, people say, well, why are we doing so well? And people will often say, oh, well, it's because we're so innovative. We've innovated, done this fantastic innovation, and that's made us do so well. But prior to about 150, 200 years ago, all we had was innovation. We had no evaluation that worked. So the innovation was like all the different historical counterfactuals were people innovating all over the place, but with no real means of distinguishing between what worked and what didn't. So we only had innovation. We had bloodletting, power of prayer, boring holes in people's heads for mental illness, drinking urine, lobotomies. The big stink there is really about just putting the sewage in the drinking water, smoking, being rubbed with a live chicken for the plague. So this is really, so actually what I think is we should be bearing in mind is it is not, there was no shortage of innovation. What there was a shortage of being able to use evidence to know whether something worked or not. And the combination of lots of innovation and the ability to distinguish between what works and what doesn't work allows us to go in the right direction and actually have really major improvements of health. And public health is a huge part of that because it is essentially health at scale. So how do we make a positive difference in public health? So I've got various guiding lights that I've put here. The first is that we actually have to take action. It's not enough to sit around doing nothing. So this is Gerard Winstanley, who was one of the early British socialists, who said, if thou dost not act, thou dost nothing. I would also add that sometimes not acting does quite a lot. So in public health, we are often having to act in the face of uncertainty. We have to act carefully in terms of risk management. So Edmund Burke, who's more famous for saying, all it takes for evil to flourish is for good men to do nothing. But he also said, early and provident fear is the mother of safety. So actually public health is about being afraid and sometimes being very afraid. Then I think this is politically very important at the moment is Voltaire, which is, he's paraphrased here, the link between what you think and what you do. And also the importance of dealing with unchecked power. So he says, those who can make you believe absurdities can make you commit atrocities. So not only if you believe an absurdity are you likely to commit atrocities, but people who can make you believe the absurdities can make you commit the atrocities. So there's a lot of public health that relates to that particular issue. And it's not only in sort of wartime or genocide or, you know, extreme circumstances. It's actually also the vested interests that we have to deal with day to day who bring about a lot of health damage. It's about different powerful agents making people believe absurdities that then leads them to commit what I would call atrocities. And then one of the other things that happens in public health and epidemiology is quite often when I'm doing cross-disciplinary work, people will say, well, what is your conceptual model? And they'll go, can you please draw a conceptual model of how these things work together? And Eleanor Ostrom, who's a Nobel Prize-winning economist, did some work which showed that something that works in practice, you can think of the theory for. So quite often I would talk about, I mean, obviously we all have a conceptual model, but I would say that public health has conceptual models that are rooted in pragmatism, and that we need to make sure also, she also had a lot that was about feedback. And then I would also put the words of Skunk Anansi, a brilliant punk rocker, who said, yes, it's effing political, everything's political. So not only do you have all of these different things at play, but everything that we do has a political dimension, whether we like it or not. So I summarize the relationship of epidemiology to public health in terms of this broad spectrum. And I've done it with a sort of trying to do the color fading. So because there's across this thing, because there are nuances, but you know, it's not, these are not absolutes. But at one end you have kind of epidemiology and at the other end you have public health. And I see epidemiology as taking what I would call collective experience. And by collective experience, I mean the lives we have all led, data, all the different knowledges that we already have, the systems we live within, the history and the expertise, that collective experience, we as epidemiologists bring together and craft and create collective evidence. And that's quantitative, qualitative, different kinds of analyses, syntheses. We can be doing sort of modeling and hypothetically, and also the science of implementation. And those things together then bring us to points of collective action, because one of the main hallmarks of public health is it completely requires collective action. Almost invariably, you have to have some form of social license to do something at scale. Obviously, COVID really brought that into relief, and in that we were only as effective as the population that were doing things. But there are multiple examples where public health means enlisting the population, and that includes acting mainly through policies and programs, through practice, through politics, through the community. And there's a very big element of public health which is commercial in different directions. So when I think very much about that collective experience, collective evidence, and collective action, and the feedback loops that work there too. Because once you've taken collective action, you need to be monitoring that you are using your data, that you're actually improving things, and you need to reinforce the things that are working and extinguish the things that are not. So we avoid the boring holes in people's head or rubbing people with a chicken for the plague. So the other thing that I think about a lot is how data work in those feedback loops. So one of my other favorite quotes is by Bertolt Brecht on the life of Galileo from 1938. And he said, "The aim of science is not to open the door to infinite wisdom, but to set a limit to infinite error." And I think if you think about that historical counterfactual, it was essentially, there was a whole morass of things going on, some of which were erroneous in terms of leading us in the wrong direction, and some things which were beneficial. And I would add a little nuance there, which is it's not just about science, it's about data. Data allow us to know when we're making an error or not. And I think quite a lot of people think that science is about opening the door to infinite wisdom. And I think it's really a very important part of how we operate in the world to know that it is very, very important to be able to falsify things. So I'm going to talk about some of the villains here in public health. And this is not a comprehensive list. I'm very happy if people want to add to it. I was just thinking it was probably good to think about starting, framing it. So obviously in public health, there are some serious biological things that are harmful to us. And over the millennia, we have been dealing with them. So those biological things, include, different bacteria and injuries and parasites and all the different things that harm us. But what's interesting is those biological things are then in the context of how much we know about how to deal with those biological things. And they're also in the context of poverty and inequality. And then they're also in the context of vested interests, and in particular, the ability of different groups to profit and exploit other people. And I think there is a villain which is kind of power without oversight. So if you imagine a world where there was no regulation of people's ability to make money or to exploit other people, you can really see the effects on public health. And I think one of the biggest things that the villains use now, and historically, is normalization. So by normalization, I mean the idea that what's going on is completely normal and nothing to see here, and you don't need to do anything about it. So if you think about what was normalized, centuries gone by, it was completely normal to own somebody else, or it was completely normal to be able to beat people if you wanted to, or it was completely normal to distribute smallpox blankets as part of colonization. But I see normalization all around us as part of the actions that people seek to harm health for their own interests. And I can use, there's lots of it in the commercial determinants of health. Like, it's completely normal to drink non-nutritious, sugary drinks at any age. It's completely, I've got something here. I don't know, I've kind of conceptualized it as the Italian factor, but I've just recently come back from traveling in Europe, and it is completely normal in Italy, for example, and lots of places in Europe, to smoke everywhere. And it is completely normal for even, I stayed in places where there were doctors who smoked. And the issue, and you cannot, once something's normalized, if you want to have a conversation about it, you are a deviant. So it's extremely powerful. And part of the process of normalization, I was just talking earlier with Erin, is that is to help people have to lose perspective to normalize something that is harmful. There are also lies included in it and a whole lot of other things. There's victim blaming as well. So part of normalizing smoking is to say, well, people choose to do it, so nothing to see here. So there's a whole range of things that go with normalization, which is about avoiding collective action. It's about avoiding the community saying, I'm going to do something powerful about that. I mean, there's other things that go on here. So I'm really happy to have conversations about the villains by anyone who wants to have a conversation about the public health villains. But this is really a first kind of series of thoughts about it. So what does public health do to deal with the villains? As I've said, there's a huge amount that's about risk management and really about what to be afraid of and how afraid to be of it. So it's about the perspective as well as about choosing what to be afraid of. It's about that experience, evidence, and action. So listening and learning and making a difference. And it's about countering the forces of evil by ensuring that we have a perspective about them that says, okay, this problem is this big and this serious, so we need to do this much about it. It is, there are some things we can do about public health that are about our immediate experience, but a lot of it is about counting because it's about health at a population level. It's not intuitive necessarily. So there is a saying that medicine was largely ineffective until we learned to count. And population health is nowhere more true when it comes to population health. As I've said, it's based on the population, but it's also about the role of the individual within the population. So it has to be not only having a really great series of plans at a higher level, it's got to go all the way down to the granularity of the individual making informed choices in the positive direction. I do quite a lot of knitting, and so I've got some knitting in my bag. And I think of it that you've got to, in public health, you've got to think about who the public health is for. You've got to have a really good pattern. You've got to have it made of the right materials. And then every stitch has to be right, because even you drop one stitch, so it's incredibly layered, and it requires a huge amount of actions in a very organized way. It is very pragmatic. It's iterative, and it's also incremental. And that's another thing that makes it difficult for the community to absorb it, because most people have a lot of difficulty dealing with understandings of risk and probability. That's why people, they will tend to buy lottery tickets, and they will also not necessarily appreciate the slow incremental effects of change. But in my lifetime, in our lifetimes, there have been huge advances in public health. When I was growing up, it was quite normal for men in their 40s and 50s to die of heart disease. That was, and the peak age of cardiovascular mortality was 1968, the year I was born. And we have between 150,000 and 200,000 fewer premature deaths every single year in Australia that compared to what we would have had if we kept on going at peak rates. Those 200,000, 150,000 people don't know who they are. Up until recently, some of them were listening to Alan Jones on the radio. Living happy, fulfilling lives, but they're not looking tearfully up into the eyes of a public health doctor and saying, I would have been a goner, but for your tobacco control policy. Yeah, so that population health thinking is very important. Based on probability, there are huge benefits, but there are also huge risks of getting it wrong. So it is naturally cautious, incredibly cautious. It has to be, and it has to be based on managing risk. It is not about having a red hot go, which I think a lot of people think it is. And as Goethe says, thinking is easy, acting is difficult, and to put one's thoughts into action is the most difficult thing in the world. So we are here at a university, and quite often people here would say that thinking and being really clever is the hardest thing. And they will not necessarily think that really creating good policy is the hardest thing in the world. But I think it is. Okay, so then I think this comes down to also a question of the way our minds have been programmed, not only by our biology, but by the myths that we have in our heads. So people are really raised on stories, and they're raised on like Marvel comic movies and fairy stories. And those stories are almost the antithesis of public health. So in those stories, the standard hero is lone, does bold and dramatic action and very rapid, usually, takes huge risks, maverick, usually acts on instincts and hunches. People go, no way can you blow up the Death Star, or don't do it, whoever, whichever hero. Usually there's a lot of violence and explosions. It's usually sort of got a supernatural, like non-understandable, non-obvious dimension. They're usually really good looking and clever. Anyway, when we come to the public health heroes, it's usually team-based. And in fact, not only team-based, it is us. It has to enlist the whole community. So it's very hard to describe the heroism there. It's very measured and cautious, and it requires a long-term vision. It's about managing risk and not doing anything crazy. It's generally working within systems, evidence-based, and it's through policy and practice. It is incredibly human. Obviously looks very, but it is also very intelligent. So some of the public health heroes, so that's Florence Nightingale, Nicola Roxon, and I forgot the name of this guy, but he did a lot of the sewerage engineering in London. So I should remember his name in future. But anyway, well, I think it's a good example. Their names are ordinary names. They're not people that you remember. And then what happens? If things are going really well? Well, obviously for standard heroes, the world or universe is saved with a single deed. And in public health, things are much better than they would have been, and that can include nothing happening. So this is Frances Kelsey. Who has heard of Frances Kelsey? Okay, so thalidomide was a drug that was licensed in 46 countries. It was available over the counter in Germany. And Frances Kelsey worked at the Food and Drug Administration in the US. And the company that made thalidomide applied 6 times to the FDA. And Frances Kelsey was the main person who said there is insufficient evidence that this is a safe medicine. So thalidomide was never licensed in the US. And I think if you can imagine what would have happened, I mean, it was bad enough what happened. There were probably, more than 10,000 people affected with the characteristic limb deformities, and about 100,000 pregnancy losses, but it was not licensed in the US. But nobody knows Frances Kelsey's name. She did get a medal from President Kennedy, but if you can imagine the amount of pressure that was on her. And what's interesting, not only does, she's working with bits of paper and things, there is an ashtray in the front with cigarettes in it. So there you go. Anyway, so there were fewer of these types of events than there would have been if Frances Kelsey had not done what she had done. So why public health should be in the firing line? Well, I probably don't need to explain why we should do public health, but it has to be in the firing line to a certain extent, because improving the health of the population often requires fighting normalization, which means you are a deviant. I was just speaking to Mike Daub, who's a kind of hero of tobacco control, and I'm sure he won't today, and I'm sure he won't mind if I write the word deviant across his face. But I was certainly in situations in Europe where I was with people who were smoking, who were talking about wanting to maximize their health, and it was extremely difficult to say, have you considered giving up smoking? Even though that is such a blatantly obvious thing, because the normalization was so strong. And that normalization wasn't just cultural normalization, but individuals who have addiction will have rationalizations and normalizations within their own self. And as an empathic person, it's difficult to state that. It requires action from the community, and not necessarily, and sometimes that's to do with things that people like to do. like driving really fast or drinking a lot of alcohol and then driving really fast, or eating, junk food or whatever, you are often labeled as the fun police. But I think what is important to remember is that that labeling actually has agency in it. It's not a coincidence that the vested interests will say, oh, these party pooper public health people. You are protecting the community from vested interests, and those vested interests will what we call screen. So there's a thing in public health called the screen test, and particularly in tobacco control, we check to see if industry is screaming. And if industry is not screaming, we will know we have not done our job. But if industry is screaming, then we know we have. And I think, one example is the tobacco industry does not want Australia's tobacco control or e-cigarette control to work. And so they will call it Australia's failed tobacco control over and over and over, with the idea that that will then become true, which it obviously isn't. They will also create doubt, so tobacco industry and other vested interests are known that it's a very good tactic to create doubt. But we in public health have to take action in the face of uncertainty. That's part of managing risk. And obviously with tobacco control, there are many things that are not uncertain. And then you're often balancing trade-offs. So there will be winners and losers quite often in public health. And what you're doing is thinking about, well, how can I get the strongest possible public health effect while minimizing impacts to people who might be losers in a particular thing. The community is diverse. And so there will always be 5% of people who, for example, believe that vaccination is wrong, or, there's a proportion of the community who won't believe in things, and knowledge and priorities vary. And the other thing is that public health words are ordinary words. So when a public health person says, right, we really need to shut the borders, there will be a different response to if a nuclear physicist says, we need to reverse the signal transductase inhibitors, or that I completely made up. But the technical language matters. And there are ways in which public health expertise is often undermined because people think, well, that's pretty obvious. I knew that. I know how to do this. And that's not just from the general public. It's even, I found particularly within, say, medicine, there is a disparaging of public health because the words are ordinary words and people think that they know how to do it. And I've given grand rounds and talked about some of our findings, and I've had a cardiologist or whoever come up to the end and say, well, that was pretty interesting, actually, obviously. Can I have a play in your data? And I say, sure. Well, yeah, sure. Can I have a play in your cat lab? But yeah, the assumption is their words are ordinary words, and there's an assumption that it's straightforward. But I would argue that an element of doing our job, and depending on where you are in the whole system, but within the system, if you are really doing your job, there will be times when you are in the firing line. And a mark of success is being in the firing line. Obviously, you do need to evaluate, and I will get into that, because sometimes you're in the firing line because you've done something wrong. So that's obviously part of your feedback and evaluation. But in general, if you're doing effective public health, you will be in the firing line. So let's think about some of the achievements of public health. So, and I think this is really, really important perspective to have, because people normalize how we are, and they also feel loss more than they feel potential gain. So going backwards hurts. So global life expectancy of birth, apologies for the typo, has gone from 32, this is average life expectancy of birth, has gone from 32 in 1900 to 72.9 in 2019. And this graph here is showing the life expectancy across different regional areas according to the sort of WHO or the UN categorization of countries. And you can see that in all of those areas, including Asia and Africa, massive improvements in life expectancy at birth, to the point where average life expectancy in Africa exceeds average life expectancy in Europe in sort of the late 1940s. So it's actually, there's been globally huge increases in life expectancy. Now we have to bear in mind that there is massive inequity both within countries and between countries. So that is not to discount this. This is these are massive changes. And obviously key elements of that have been about sanitation, nutrition, economic development, vaccination, motor vehicle safety. I've just put this big long list. And each one of these is about denormalizing what was normal. It was normal to drive to not have speed limits. It was normal to drive while you were drunk. It was normal not to have seatbelts. Each one of the changes in public health met with quite a lot of resistance. But, you know, there are ways in which they have prevailed to a variable extent. I did definitely notice in Italy a lot of people on motorbikes on the mobile phone while they were going along with the most spectacular ability to navigate tiny corners. I just could not believe the level of coordination that people had there. Safer workplaces. It used to be normal to accept that a certain number of your workers would die and that you wouldn't have to provide safe working conditions for anybody, including children. Control of infectious diseases, as I've said, declines in cardiovascular disease deaths. And those have multiple reasons why they've happened. And they do include control of tobacco, control of blood pressure, lower cholesterol, changes in saturated fat intake, safer and healthier food. So it also used to be quite normal for food to be unpredictably harmful, you know, so you would not have properly stored or prepared food. Healthier mothers and babies, family planning, fluoridation, recognition of tobacco use as a health hazard. And as I've said, there is still massive inequity that we have to bear in mind across all of these gains. So I just wanted to give you a bit of an example about being in the firing line and the role of vested interest by talking about some of the work that I and my team have done in tobacco control. I think as background to this, I was asked by the editor of Cardiology Today to do, he said, Emily, could you write an editorial called Sitting is the New Smoking? And I said, well, look, I'm really happy to write an editorial, but can I call it Smoking is the New Smoking? Because I don't think we need a new smoking. And I am a big fan of gonzo journalism. I don't know if you've heard of Hunter S. Thompson, but the whole thing with gonzo journalism is it's pulling back the frame. So if you imagine normal journalism would go, Senator McGovern unveiled his 3-point plan in Wichita, Kansas today. And the gonzo journalist would say, you know, I woke up face down in a greasy motel, having drunk too much. All the journalists piled into some van and were driven to Wichita, Kansas, where there were tumbleweeds blowing across the thing. And Senator McGovern climbed sheepishly out of a chauffeur-driven limousine and stood on a platform and unveiled his 3-point plan. So it's a kind of, it gives you a lot more texture. Anyway, I wrote what I think, and I would love to partner if anyone wants to do some gonzo epidemiology, totally up for it. But anyway, I did say, I was asked to write this editorial of Sitting is the New Smoking, and I reflected on why I would be asked to do that. And I could think of only a handful of reasons, but they included that people underestimate the harms of smoking. They think it's solved, and they think it's boring. And those things are a direct consequence of the tobacco industry. That's what the tobacco industry wants us to think. And the fourth thing they want to think is that it's the people who smoke's fault. So that's the fourth thing. They want to blame the victims. So I would like to tell you why it's exciting. Well, first of all, why the harms are large. I want to tell you that it's not solved. I want to tell you that it's really exciting. And I want to tell you that it's not the fault of people who smoke. The sole cause of tobacco smoking and the tobacco epidemic is the tobacco industry, and it's the sole cause of it. So tobacco smoking causes more than 8 million deaths annually, and that's more than 10% of deaths worldwide. So it's a good party trick. You can say to people, how many deaths are there in the world every year? And you can sort of say, depends whether you're in the middle of a pandemic or not, but it's about 60, 70 million at the moment, you know, and you can, but, you know, good to have a handle on those ballpark figures. But that means more than 10% of deaths worldwide are attributable to tobacco. And there's obviously huge amounts of morbidity as well, of suffering that's caused by that. It's more than 20,000 deaths annually in Australia. So we've been doing some work, and that Grace Joshi's been leading, really revising that figure. And you know, it's a little bit more than that. I can't reveal the details at this point. What we do know is that 50% of deaths in Aboriginal and Torres Strait Islander people aged 45 and over are attributable to tobacco. So despite really large reductions in smoking in Aboriginal communities who have, you know, tirelessly combated the tobacco industry, we are still looking at 50% of deaths. So when people say, how can we possibly close the gap? How can we possibly improve things? There's a serious no-brainer sitting right there. We estimate that there were around 100 million deaths due to smoking in the 20th century. And we estimate that there will be 1 billion in the 21st century unless we accelerate tobacco control. Now, the 100 million in the 20th century is sort of understandable, sort of forgivable, because we didn't really tumble to what smoking did until maybe 1950. So there was serious delay there anyway. But we know what tobacco does. So that 1 billion is harm that really could be readily prevented. There is massive inequity in the distribution of smoking, and also smoking is a massive cause of health inequalities. Tobacco is the subject of the very first international public health treaty, which is the WHO Framework Convention on Tobacco Control, which includes really comprehensive suite of measures, including ways to combat the tobacco industry. But as I've said, it is regarded as boring. And there is, you know, up until recently, there was really stagnating action in Australia. Up to 2/3 of all people who smoke in Australia will die from their habit if they don't quit. Now, let's reflect. That's using the product according to the manufacturer's instructions. These people are not doing anything weird with the cigarettes. And if you had a car where 1 in 10,000 of them had brakes that didn't work properly, you would have to recall the car. Like, you would have to do something about that car. So it's the fact that these products were grandfathered in before we had strong regulations, and they continue to take a huge toll in Australia. And then there is a resurgence of the tobacco industry that relates to their harnessing of novel products, particularly electronic cigarettes, but also nicotine pouches, nicotine toothpicks. The big motto now is nicotine for every occasion. So places you can't smoke, you can vape. If you can't vape, you can use a nicotine pouch. So you can keep that nicotine going. In the corner here is a product from Denmark called Virgin Box, and it is a box of nicotine pouches designed really, I have been told that it's a present for a teenage girl, essentially. And it starts with a sort of peachy flavored one that's a lower concentration, and it sort of works the way up until finally you can have the stronger mint one. And then there are these disposable vapes, some of which have the equivalent of more than 20 packets of cigarettes worth of nicotine in them. So what are the tobacco industries? This is just the perfect villain. There's even these little pictures that you can get on the web of them being villains as part of sort of WHO. So they have a really long history of their tactics, limitless resources and essentially zero scruples, a playbook for other actors. And actually their tactics are a large area of research and scholarship. So it's a really interesting read. If you want to have some good bedtime stories, it's excellent. A lot of what they do is to challenge and evade regulation, which is challenging and evading public health. And one of the things they do is have rapidly changing products and product characteristics. So the FDA in the US has literally millions of products that they have to deal with in order to regulate. Here are just some, this is a whole lot, you can't read the text, but just a whole list. So WHO and a group called Tobacco Tactics have a taxonomy of the tactics that the tobacco industry does. But just some examples and broad brush is that they discredit, create doubt about proven science. They conspire to hijack the political and legislative process. So there are countries that are essentially captured states to the tobacco industry. They intimidate governments with litigation or the threat of litigation. So what they will often do is, if governments take strong measures, they will take those countries to court, and they don't care whether they win or lose, because just the process has a policy chilling effect. They will exaggerate the economic importance of the industry. They will maintain public opinion to gain the experience. They will manipulate public opinion to gain the experience of respectability. They will fake support through front groups. And they will undermine, I mean, this is just at the bottom, for example, smuggling. They will undermine tobacco excise tax policies and marketing and trade restrictions with smuggling. They will exaggerate the importance of the illicit tobacco problems. There's a huge range of essentially manipulation of information and other things. So they do information management and attack public health evidence. They do reputation management, which attacks public health advocates, and they do coalition management, where they try to fragment the public health coalition. They litigate and they exaggerate the importance of illicit trade, as well as creating illicit trade. And as Bronwyn King, who is this extraordinary tobacco control actor who has, she was a radiation physician looking after people with a lot of the time with lung cancer, found that her pension fund was investing in tobacco companies, and basically confronted that, managed to get them to disinvest. And she has since then gone on to spearhead the disinvestment of literally billions of dollars from the tobacco industry, nationally and internationally. So if you want to see a really inspiring story, then tobacco-free portfolios. So let's put things in perspective about where we are with tobacco, but also where we are with novel products. This is a square, a sort of rectangle representing the Australian population, and the blue is the people who are not current daily smokers. So it's actually more than 90% of the population now. The group on the side here are people who smoke daily, and that's now 8.3%. And of those people, around 40% will make a quit attempt in a given year. And of those, about a third will use a product. So in fact, between about 2/3 to 3/4 of people who quit smoking successfully do so unaided. So quite often you will hear people who talk a lot about e-cigarettes saying that these people need these products to quit, but actually the majority of people will quit without a specific product. So it's still a substantial part of our burden of disease. It's still our leading preventable cause of burden of disease in Australia. So we have to be able to hold in our head that it's still a massive killer. It's about 60 people a day in Australia will die from a smoking-related disease. But we have been very successful in reducing smoking. So keeping that perspective in mind, that perspective is a very important thing for combating the tobacco industry and the rhetoric they seek to tell us. We have to, as public health people, protect, I won't go backwards, but really protect those people who are not smokers from, and particularly if you look at this picture for young people, it would be even more blue. We have to avoid those people getting addicted to new products while helping these people to quit. And quite often people say, well, we need e-cigarettes and these new products on the broad open market because of this group on the side. And that the other people, like the young people, they're just unfortunate collateral damage. But actually, they are the main target of the tobacco industry because they are the future clients. And addiction is programmed off usually during youth. Most smokers, there's almost universal regret among smokers that they, 80, 90% wish they had never started. and almost all of them started as teenagers. So that's another thing about getting away from it being smokers' fault. They were addicted actively by companies as children. So how did we combat a lot of the vaping stuff? Well, we used our collective experience, and there's a huge number of different studies. And this is also to do with smoking. So this is a photo at the launch of the revitalized, no, actually, that's the 10-year anniversary of plain packaging, but it was very close to the launch of the new Public Health Tobacco Act. We brought together collective evidence on smoking and mortality, the general population, First Nations, cardiovascular disease, cancer. We just kept going, like essentially we kept going. We had a whole lot of collective action. It was a huge number of people, and we had a strategic approach. There was a huge amount of pushback, including a lot of international pushback and a lot of social media and scientific pushback as well, but also pushback from politicians. So that's a photograph of Holly Hughes with someone who is associated with the vaping industry. So we can, and I think one of the other things that's been happening is there's been misinformation also that vaping has reduced, that vaping is has had a key role in reducing smoking in Australia. This is a graph really showing one of the key drivers of reducing smoking prevalence is likely to be price. So that red line is the tobacco prices expressed as an index based on supermarket sales data and ABS retail survey data. And the blue line going down is smoking prevalence, current smoking prevalence. And we know from World Bank data that for every 10% increase in tobacco price, there's about a 4% decrease in prevalence of smoking. And that broadly ties in with that. Vaping is the green line at the bottom. That's the prevalence of at least weekly vaping. So it may have contributed some small amount, but mostly the likely culprit is this increase in price. So happy to talk more about that. Anyway, how do you deal with being in the firing line? So this is me at age about 3 or 4. That's kind of how I feel inside a lot of the time. And I also have worked out that I really want everybody to love me. I really want people to be happy, and I want everyone to love me. So it has been incredibly difficult for me to deal with being in the firing line, and particularly to be criticized, because one of the other, if you are a perfectionist, and I have a bit of that, people criticize you, it's particularly wounding, but also it makes, it just generally makes you feel terrible. So the first thing is, you have to be really careful about how you deal with it, and recognizing that you're in the firing line. Actually take a step back before reacting and think, how am I going to approach this? These are just some ideas that I have, but everyone has their own personal journey. One of the most important things is to limit the amount of exposure that you have to this. And Nietzsche says, he who fights with monsters might take care lest he thereby become a monster. And if you gaze for long into an abyss, the abyss gazes also into you. So it's really important to think how much exposure you want to have. So it's also really important to prepare and protect yourself, your work, and your colleagues. And there's a whole lot of stuff here about collaborating, connecting, working out, defining your work plans, be as confident as you can in what you're doing and your policies, but also understand the tactics of whoever you're working with and their history. Define success to include pushback, if pushback is likely, and consider what drives you, like, me, and reprogram yourself. So I'm not saying I've necessarily been particularly successful on that, but I think I've gotten better with dealing with pushback. It's important also to be proactive rather than reactive, because a lot of these actors will seek to hijack the agenda, and they will seek to increase their prominence. So we have a policy within our team that we don't actually respond. We don't engage in scientific debate with people who are funded by industry. We don't legitimize it in that way. You need to focus your energies on what you want to achieve and limit exposure, and avoid legitimizing vested interests, and defer to the evidence. That's the other thing. It's really good to do the third way. So in Senate inquiries or whatever, people go, you really suck. and you've done this, and then you go, look, I wish I could change the evidence. You know, I would love it. I would love it if the news wasn't that bad. But unfortunately, the news is really bad. I wish I could change it. But look at the evidence. And so try, you know, deflecting to that. Then also, you do need to evaluate, oh, and you can pull the frame back a bit. You can go, you've got a vested interest. It's good to keep an open but not too open mind. So in some of the criticism, there may be things that you do need to change. There may be things that you do need to reflect on, but don't open up a whole well of, you know, don't open up too much doubt, and have a care plan for the inevitable bad times, because they will happen. Make sure you slow down, don't react too quickly, use your support networks, use the institutional support that's available to you, and have some, you know, calming and comforting thoughts, and, you know, chocolate, whatever lights your candle. And there's some fantastic work by Julie Leask, who does a lot of work on vaccination, and a sort of acronym that she uses called STEADFAST. So I really recommend that. So concluding thoughts, we you know, keep on going and be brave, accept that our fight is long and hard, try to maintain your perspective and continue your fidelity to the data, because that is your defense that what you are doing is right. Be proud. I think we have to work on our narratives, because we have to counter the programming that people have had all the time, which is that a single hero will come and do something bold and everything will be fixed. Keep it real. Combat misinformation, continue to speak truth to power, and continue with our systems-based approach and our partnerships. And then you could even ask yourself, am I sufficiently in the firing line? So, yeah, and there's Francis Kelsey. So back to my final sort of mantra, my mantra on this, which is, remember, those who can make you believe absurdities can make you commit atrocities, and that includes you. So if they can make you think that what you've done is wrong, and you're right, you know, you could actually be undermining yourself. Finally, I'd like to say thank you to all of the heroes in public health, because we often don't know who they are. But the other thing is, the community is the ultimate hero of public health. And across the world, we've had incredible achievements. Thank you very much. I only left 5 minutes for questions. Steph.
Thanks for the presentation. I was interested in the fallback to evidence. There was a really interesting discussion on the radio yesterday about how our language is changing, and people are saying "I feel" rather than "I think." And there's this sort of discourse that if you can't, as soon as someone says "I feel this," and the dominance of feelings in our language, it's very hard to counter with fact and evidence. To what extent, when you say hold on to the evidence, is that actually getting harder, or is it getting easier from your perspective in the data? Is it still has value, even if we know being evidence-based it's right? Is it losing any currency in the discourse?
Well, I don't actually have any evidence about that. I'm quite serious. Yeah. I have no idea. I mean, I think, you know, I think it's really, really important to note our progress and think about our measures that we are actually monitoring, to say, are we losing public health purchase in certain areas? And there's definitely issues with stagnating gains in mortality, particularly among men and middle-aged men in Anglophone countries, actually. So there's just examples where we're possibly going a bit backwards. But on the other hand, we are still seeing gains in mortality. So, but I think it's a very good question. And I think there are lots of questions about those sort of mechanisms. Like, I think you can be monitoring not only what public policies that are health positive are happening, how well are they being implemented, and then how well are they being taken up before you get to those other longer term sort of health outcome measures. But I think it's not a coincidence either that people are kind of getting this license to say, well, I feel this way, so I'm going to do this thing. Quite often, I mean, it sounds really, I'm not big on conspiracy theories, but I do think that quite often you can look behind them and you do find vested interest, because it's not in the people who are seeking to profit. It's not in their interests to have people, you know, gung-ho on the data. And also I think there's an issue with how boring people think it is. Like, you know, there's people who can tell you who won the Ashes every single year for 50 years, but they wouldn't be able to tell you how well we're doing in terms of cardiovascular mortality. And so they're more vulnerable to misinformation because they don't know that we're doing really well. So, you know, we've got these massive improvements in cardiovascular mortality. And if we'd won the Ashes every year for the last 50 years, nobody would go, let's change the fielding, you know. So that, but I think it allows people to question that. So I don't know if it's getting harder, but it's certainly hard enough already.
Is that there are social surveys around the lack of trust in science, that scientists used to be about science, and there's a real change in community that scientists can't be trusted. That's coming down, which is sort of like science. So, and I guess America is a good example where people are now sort of ignoring science and something that's just there's very good theories, but climate change is a good example. Yeah. I think it's happening in health as well. Quite a really important out. Got the people who's in charge of health in the West now.
Yeah, and I think, you know, it's interesting actually, because I think COVID was a good example, and then the level of adherence to public health messaging, you know, public health measures was very high in Australia, and people didn't think that would happen. They sort of thought, oh, well, Australians won't do that. But a lot of it is to do with not only trust in science, but also the social contract, like the extent to which people do feel supported by Medicare or not. I'm not sure it necessarily happened to the same extent now because people have been through it, but you can also see that in parts of the US, there wasn't a very strong social contract, and people didn't trust the science. And I mean, everybody's born a baby, you know, like, and we're all shaped by the culture we grow up in. So I think it, you know, it is, yeah, our fight is long and hard.
Just sorry, for the people on the webinar, would you mind repeating the question?
Oh, sorry. The question was, I'll try and remember this, that quite often now people will say, I feel, instead of I think. So there's this kind of idea that people are less inclined to be deferring to evidence, and they're able to justify whatever, well, their actions by how they feel. Is that a reasonable summary? Yes. Yeah.
We also had one more webinar question, which is from Anne-Marie Farrelly. She said, thanks, Emily. Great presentation and quite empowering, which is welcomed. I'd be interested to hear your thoughts on tobacco prices and smoking prevalence relationships, and how this may change in the increasing accessibility to illicit tobacco, pop-up vapes and tobacconist stores, where access and prices are no longer a barrier to smoking, especially in groups with health disparities.
Yeah, so this is a very good question, and certainly illicit tobacco is a key issue in Australia, but I think we need to keep it in perspective. So we still have, like, it's not the majority of tobacco sold, and we know that the tobacco industry exploits illicit tobacco in order to try and justify that regulation is not a good idea. So we do know that price is one of our strongest, I think it is the strongest barrier to smoking, and it's particularly important for young people not taking it up. Like, teenagers will say, look, why would I spend that much on a packet of cigarettes? And so what we need to be able to do is maintain those prices at the same time as combating illicit tobacco. Very happy to have the interim illicit tobacco and e-cigarette commissioner here in the audience today. So, you know, I think it's really important that's being taken seriously. So there are ways of combating illicit tobacco. I think what the industry wants us to think, and they really play with illicit tobacco. They want us to go, oh, illicit tobacco is really bad, so we'll stop doing price increases. And that's like saying, well, even though we've got speed limits, people are speeding, so let's get rid of the speed limits. It's not really, and it's not a sensible public health strategy. I think we also have to remember that tobacco, the WHO Framework Convention on Tobacco Control includes a really wide range of activities. It's not only price, it's also things like licensing, it's about control of the contents of the product, it's about education, it's about plain packaging, bans on advertising. It's incredibly comprehensive, so it's not one thing. And the other thing we have to remember is that the industry will also manipulate people's awareness of illicit tobacco and its impacts. So we don't hear on the news every day another 60 people died of a tobacco-related illness, but we will hear a tobacco shop got firebombed. Now, I think we need to bear in mind and maintain perspective on what is the dog and what is the tail. And the dog is kind of the tobacco-related injury and illness and harm, and also tobacco control, and the tail is illicit tobacco. It matters, but it should not be allowed to derail the whole tobacco control framework. Jenny.
I don't think I'm going to say this very eloquently, but so forgive me. But what I've noticed, so I mean, you're up against it, right? Because you have a really well-resourced villain who is really powerful, and you know, I'm sort of aware of some of those cops that you guys play, right? It's unbelievable. In some ways, it sort of makes it's not easy for you to deal with, but they're a very well recognized villain, right? Like they're not a hard group to point out as a villain, right? Do you think it changes when the villain is slightly sneakier or is slightly more complicated? Like I can imagine, you know, I do lots of work on inequalities, so I can imagine certain, government, what's the word? Like people with different leanings, right? I can imagine that people who are quite wealthy and who don't want to give up tax cuts and that sort of stuff, that they could be a villain in the sort of work that I do. Do you have any thoughts on whether it changes depending on the villain? Yeah.
So the question is, and correct me if I don't get this right, the question is, in tobacco control, you can have a very specific villain, very well resourced, you're really up against it, very hard work. But in some ways you have the villain, like you have a really clear villain, and you can do policies around that villain. But you can be working in an area of public health, for example, on inequalities, and the villain can be much less clear and much more opaque as well. So it could be the collective actions of lots of individuals who are really wealthy and don't want to give up tax cuts.
Yeah, funders.
They could be our funders. They could be government policies, or anyway. So there's so does that make it harder or does it make it easier? And I think you can really see by the actions of the tobacco industry, they seek to make things more complicated. They seek to make there be more doubt. They've diversified, you know, there's a tobacco company that's even bought into medical inhalers. So they know that if they create doubt, and sometimes they're the good guys and sometimes they're the bad guys, that's in their interests. So I totally agree that both from a kind of effectiveness perspective, but also from a kind of personal perspective, it can feel really hard because you've got no one, you know, what do you do? There's so many different things that you need to be doing, and there's no one particular thing to blame. So I think I suppose it makes it easier in some ways and harder in others. But it's also, I think, very, very complicated. It makes it very, very complicated. So I think dealing with inequalities is particularly complicated because there's also no one part of government that would really need to do something about it, and no one part of society. It's a much broader issue. So I think it does make it harder, but possibly less flack.
Yeah.
So harder in some ways and possibly easier than others. I think that's probably, we're out of time, aren't we? Okay, well, thank you, everyone. Thank you to the people online. I'm definitely up for any sort of conversation about any of this. In fact, I see this as part of a conversation. But anyway, thank you.
Thank you, Emily.